We think it's essential for patients to know how much visceral fat they have because that's one of your primary risk factors for impaired glucose tolerance and high blood pressure and high cholesterol. Once you know those numbers for yourself, then we can get you on a plan for how to start to reduce that number over time, thus reducing the number one cause for mortality, which is cardiovascular risk.
Here are the numbers that should wake everyone up. Heart disease is the number one killer in the US. 655,000 Americans die from CVD annually. That's one person every 36 seconds. 126 million US adults have some form of CVD. That's roughly 1 in 2 adults. This includes coronary artery disease, heart failure, stroke, and high blood pressure.
Welcome to MD Longevity Lab, where we're playing the long game. This is a podcast where science meets real life with expert insights, practical tips, and real-world tools to not only live longer, but live better. Our aim is to radically change the way medicine is practiced and enable individuals to age gracefully, maintaining health span and vitality well into their later years. We're your hosts, Dr. Nisha and Dr. Vikas Patel, physicians, partners in life, and parents balancing work, wellness, and everything in between. Let's dive in. Welcome back to the MD Longevity Lab podcast, where we are playing the long game. I am your host, Dr. Vikas Patel, and I am again joined by my beautiful co-host, Dr. Nisha Patel. Today, we are going to take a deep dive into cardiovascular disease, which is actually the number one killer in America. And let's be honest, probably the number one reason why I've been eyeing a treadmill in our basement with equal parts guilt and dread.
Well, at least you're looking at the treadmill. That's a good start. Yeah, cardiovascular disease is such an important topic. You're going to hear us abbreviate cardiovascular disease as CVD. In this episode, we're going to cover everything you need to know about cardiovascular disease, the basics. So hopefully you'll leave this episode with a great overview. We're going to cover some important statistics of CVD, risk factors, both modifiable ones and non-modifiable ones like Lp(a). We're also going to give you a condensed overview of the pathophysiology of CVD. We're going to try and cram 4 years of medical school and 3 years of residency and what we learned about CVD into this 45-minute podcast. But before we jump into the scary statistics, let's make sure everyone knows what we're actually talking about when we say cardiovascular disease.
Yeah, good point, Nisha. So CVD is an umbrella term that encompasses several conditions affecting the heart and the blood vessels. So we're talking about coronary artery disease, which is the narrowing or blockage of arteries that supply our heart with blood supply. Heart failure, which is where the heart can't actually pump effectively. Strokes are when essentially the same problem as happens with a heart attack. There's an interruption in blood flow, but this time it's to the brain. And peripheral artery disease. Peripheral artery disease is the same problem where blood is not able to flow into the arteries in our limbs. And one other thing that contributes to all of this is hypertension. Hypertension is elevated blood pressure. And there are so many different risk factors and conditions that totally affect the cardiovascular system.
Yep. So the common thread in coronary artery disease, peripheral artery disease, heart failure, and stroke is usually atherosclerosis. And atherosclerosis is the buildup of plaques in your arteries, though heart failure can have other causes too. Think of your cardiovascular system as a complex highway network, and CVD is basically traffic jams, roadblocks, and infrastructure failures all rolled into one.
Yeah, I think that's a perfect analogy. Now, before we kind of scare everyone into thinking they need to start training for a marathon tomorrow, let's set the stage with some numbers that might shock you a bit and not in a good way, like a defibrillator.
Here are the numbers that should wake everyone up. Heart disease is the number one killer in the US. 655,000 Americans die from CVD annually. That's one person every 36 seconds. 126 million US adults have some form of CVD. That's roughly 1 in 2 adults. This includes some of the conditions we talked about, like coronary artery disease, heart failure, stroke, and high blood pressure.
Yeah, and the economic impact is staggering. Right, 219 billion in direct medical costs that we spend annually, over 365 billion when you include lost productivity. That's really more than the GDP of most countries.
Yep, we could literally build a small nation with what we spend on cardiovascular disease annually. Though I'm not sure what we would do with it because it'd probably turn into a cardiac rehab center.
Yeah. Welcome to Heart Island. Population, everyone who needs a stent.
I don't know if people would watch Heart Island as much as they watch Love Island.
Love it. Yeah, I think you're right. So these numbers, unfortunately, represent real human suffering and real families dealing with devastating loss and financial hardship.
And that's why it's particularly frustrating that so much of this is preventable. About 90% is in our hands and preventable. We're essentially paying hundreds of billions of dollars for diseases that we know how to prevent.
Absolutely. Cardiovascular disease is truly one of the number one preventable causes of death. So let's get into some of the risk factors here. There are ones that we can't control, and then there are ones that we can absolutely control. So, Nish, let's start with the non-modifiable ones.
Sure. So let's cover the big non-modifiable risk factors. And those are the risk factors we cannot control. So age is the number one non-modifiable risk factor, and risk increases significantly with age. And sex, that's another big one. Men have a higher risk earlier, and women catch up in their postmenopausal years. And genetics and family history. So these are very complex interactions between genes and the environment. And we'll get into Lp(a) shortly.
Yeah, so for men, that's age 45 is when we traditionally think of as a risk factor for cardiovascular disease. And for women, post-menopause, age 55 is when we generally think that now they're at a higher risk. So often people just kind of throw their hands up about genetics, but that's kind of like saying, well, my family has a history of car accidents, so I might as well drive blindfolded.
Yeah, exactly. Even though we can't control our age, sex, or genetics. So let's go over the modifiable risk factors. And that's where we have the real power. And those modifiable risk factors are hypertension, high cholesterol, diabetes or metabolic dysfunction, smoking, and a big one nowadays, which is obesity and physical inactivity.
Yeah, we've created an environment optimized for CVD. Let's take a deeper dive into a few of these. So hypertension, the definition of hypertension kind of changed in 2017. The goal now is 130 for your systolic, the top number of your blood pressure, over 80 for the bottom number. And that used to be 140 over 90. So this change kind of made 31 million more Americans hypertensive. Hypertension is kind of the silent killer because it has no symptoms until the day that you actually have some sort of dysfunction like a heart attack or a stroke. Lipids are number 2. So LDL targets used to be, let's try to keep them under 100. Then we've moved them to under 70. And for some patients, it's really under 55. At this rate, we might be aiming for negative cholesterol by 2030. Not all cholesterol is equal, right? So I'm sure you've all heard of LDL cholesterol as the bad cholesterol, HDL cholesterol as the good cholesterol, and then triglycerides are some of the troublemakers. And now what we really want you to care about is your ApoB rather than just your LDL, as this is a much better marker for all of those quote unquote bad cholesterols. And we'll discuss this later. And then as Nisha had mentioned, physical activity, right? So I don't know how many of you are getting the 150 minutes of moderate activity per week. We know that if you're getting that, there's a 30% reduction in your likelihood of having any type of cardiovascular disease mortality. That's just 5 30-minute walks a week, right? The human body was designed to move and not sit in front of computer screens all day.
Yep. And smoking. So cardiovascular disease starts dropping almost immediately after quitting. So for our listeners that are smoking cigarettes or thinking about quitting, within 1 year, you can cut your heart disease risk in half by quitting. So your cardiovascular system has a memory of a goldfish when it comes to quitting.
That's right. All right. So let's get into some of the pathophysiology. So, how does cardiovascular disease actually develop? Nish, you want to walk us through kind of a brief history of atherosclerosis?
Absolutely. So we want to think of atherosclerosis as your artery's way of trying to help, but it's like the friend who wants to help by reorganizing your entire kitchen without asking. So it makes more work for you and it just makes everything worse. Yeah.
I may be guilty of that.
Yeah, it's like when I ask Vikas to help and he tries to help, but it's like he's just created more work for me.
That's right. So the kind of simplified process here is that there's some endothelial damage, and that's the lining of the arteries is the endothelium. There's this damage that occurs from high blood pressure, smoking, diabetes, oxidized LDL particles, all of the bad cholesterol particles. All of these things combine to infiltrate the wall of the artery, and that causes this inflammatory response. The inflammatory response can induce an immune response. And there's these cells called macrophages that try to clean up all of the damage. They unfortunately become overloaded with this foam cell, and that leads to this plaque formation. If the plaque actually forms properly and becomes calcified by your body, then the plaque is fine. Our body has essentially neutralized it. But before it becomes calcified, there's this foam cell portion that is dangerous. Those are unstable plaques and they can rupture. And that's actually what causes a blood clot and subsequently a heart attack or a stroke or peripheral artery attack. So this is the problem, is that the multiple risk factors that we have, whether it be from hypertension, diabetes, smoking, or cholesterol, all of those things in combination can cause this damage to the blood vessels. And in the progression of the damage, you develop these plaques. When they're soft, unfortunately, they can rupture and cause a clot. Once they harden and become calcified, now our body has fixed the job and they don't present a danger to us anymore.
Well, they present a danger to us in different ways, right? If it's calcified plaques.
They cause a difference in function, I'd say. So your heart needs adequate blood supply. And as long as it's getting that blood supply, even if the artery is narrowed, if you're exercising a lot, you'll build new arteries around the narrowing. The problem is that when there is soft plaque and not calcified plaque, the soft plaque can rupture, the calcified plaque can't. So if you have stenosis or narrowing of your artery down to 10% and you start exercising, your body will decide that I need to build more blood vessels around that area.
Yeah, most dangerous plaques aren't necessarily the narrow ones. The worst heart attacks often come from those stenosis plaques that are 30 to 50% blocked. And that's why stress tests that we normally run on patients to screen for heart disease, they don't always catch everything.
Exactly. So we do testing on inflammatory markers such as C-reactive protein and IL-6, TNF-alpha. When those inflammatory markers are elevated, those are signs that somebody might be at risk for one of those plaques to rupture. And so those are things that we track in our own patients.
Yeah, and let's talk about some advanced screening tools. So now that we've covered some of the pathophysiology of cardiovascular disease, let's talk about some of the advanced screening tools that go beyond basic cholesterol testing. So what should we know about ApoB, apolipoprotein B?
Great question. So ApoB, or apolipoprotein B, as Nisha said, is actually a superior marker to LDL cholesterol. Every atherogenic particle has exactly one ApoB molecule that is associated with it. So LDL cholesterol can be a bit misleading. You can have a normal LDL cholesterol, but still have a very high particle number. And think of it this way. LDL cholesterol tells us how much cargo is on the highway. ApoB tells you how many trucks there are. So the more trucks equals the more opportunity for accidents, even if they're not fully loaded.
Yep. ApoB advantages over cholesterol, let's touch on that. So ApoB is a better predictor of cardiovascular disease events than LDL cholesterol. It's a nice test because it does not require fasting like a lipid panel does. Optimal levels, we like to keep under 85 for the general population. And for some of our high risk patients with a high Lp(a), which we'll get into a little bit later, we want that number to be less than 65. It's especially useful in people with metabolic syndrome or patients with impaired metabolic function or diabetes.
Yeah. Any patient that has risk factors, essentially within our own clinic, we're always targeting an ApoB of less than 65. If you have any type of family history of cardiovascular disease, or if you yourself actually have impaired glucose tolerance or other cholesterol issues.
And we've had many patients who have had a normal lipid panel, their LDL is fine, but they're metabolically unhealthy and their ApoB levels, when we first check them, are sky high. And then we give them some things to work on and change their nutrition, their lifestyle. Sometimes we add pharmacological therapy and we recheck that number in 6 months and then ApoB number has normalized.
Exactly. One of the other tests that we tend to do in our patients are cardiac CTs. And I think this is really kind of a game changer for screening as well.
Yeah, cardiac CTs, we also call them coronary artery calcium scores. So this is a quick, non-invasive CT scan. You don't need contrast, and it measures calcium in coronary arteries, which are the arteries that supply your heart. So they're markers of atherosclerotic plaque burden. And a score of 0 means you're very low risk for the next 10 years. And a score of 100 indicates a significantly elevated risk. And a score of 400, well, we have a lot of work to do.
Yeah, so there's some practical applications here, and this is really can help to guide treatment, right? So sometimes we have patients that have intermediate risk. We don't know should they be started on a statin or not because they have some borderline cholesterol numbers. Essentially, if you have a positive cardiac CT score where you have a score that's not 0, then we know that you already have evidence of heart disease, and putting you on lipid lowering strategies is the perfect solution because not only do you have the risk factor, but now you also have evidence of disease.
Yeah. And I think nowadays we're hearing more from patients, especially in this new age of influencers and people who have no medical training, kind of poo-pooing pharmacological therapy like statins. And it's up to us to make the case for that patient, right? So if we have actual evidence that they have cardiovascular disease, like it's already been brewing, it really makes it a better case for the patient to give them the option. Well, if it were me, I would probably take this medication knowing that I actually have evidence of this disease.
This is where politics, unfortunately, and culture gets in the way of like what we actually know from a scientific standpoint is the right thing to do that's going to save lives in the long run. And unfortunately, in our country right now, we're in this period of time where politics, unfortunately, matters so much. And evidence doesn't always play a front and center role. Tell us a little bit about CT angiography, because that's a level of testing a little bit above just a regular CT, cardiac CT.
Yeah, so a CT angiogram is a test that is a little more involved. It uses contrast to actually visualize the coronary arteries. So you can see both calcified and non-calcified plaque. So theoretically, you could have a patient with a coronary calcium score of 0. And then when we do a CT angiography, they can actually have evidence of soft plaques, correct?
Absolutely. Like the problem with cardiac CT is that it doesn't show soft plaque, but a cardiac angio CT does. But it's invasive. You have to have an IV, you have to get contrast through the IV for it. We basically make the assumption that if you're over 40, 50 years of age and you have high cholesterol that's been untreated and your cardiac CT score is 0, we just make an assumption that you likely have some soft plaque because that's what, unfortunately, autopsy data shows us, right? I think in a previous podcast, Nisha, you had mentioned that there was autopsies done on patients who were only 19 to 20 years of age.
And many of them had evidence
Soft
of
plaque.
soft plaque, correct?
So if you have high cholesterol and you've made it all the way to 40 or 50, and you have a cardiac CT score of 0, very likely you have some soft plaque there. We would typically advocate that you need to be on some sort of lipid lowering strategy at that point.
I would argue it's not just high cholesterol, right? It's any one of those modifiable or non-modifiable risk factors. So if you are obese, if you have smoked in your life, if you have metabolic dysfunction, if you have a positive family history, all of these things, whether it's one or multiple, all of them can create this picture of cardiovascular disease.
I think you're absolutely correct. So I think this is something that's hit home around us quite frequently and worth bringing up. There's this gene marker, LP little a, and we've actually had some patients that have unfortunately tested positive for this and had some negative outcomes from it. So it's definitely worth bringing up here.
LP little a, we abbreviate it as that, but it's lipoprotein A. It's like the Kaiser Sose of lipid disorders. About 20% of the population has elevated levels, and most have no idea. This is a one-time test that we should be doing on every single patient. We do it on all our patients at MD Longevity Lab, but this isn't really a common test that is done in the primary care setting. And hopefully in another few years, it will be. But it's an easy test that if we do on everyone as a young adult, we can essentially risk stratify and predict your risk of cardiovascular disease. You've heard of people in your community that are young, healthy, they run marathons, or they're athletes, and then they have a heart attack and they're told, this was a really close call. You had a heart attack, and you're wondering, how did this person who never smoked, who's fit, doesn't have any risk factors, have a heart attack? And that's that silent killer, LP little a.
Yeah. So what is LP little a? It is a type of LDL particle plus this apolipoprotein A that's attached to it. Unfortunately, this ApoA particle makes it very dangerous, and it's prothrombotic, meaning it actually induces clot formation. Clot formation is what causes heart attacks. So if you have a plaque in an artery and that plaque ruptures, the types of particles that are in that plaque matter. If your plaque is made up of enough of these LP little a particles, the likelihood of forming a clot is way higher. And if that clot is in a major artery, which unfortunately LP little a tends to cause those widowmaker type heart attacks, this is the consequence.
Yeah. And this is entirely genetic. So whether one follows a rigid diet, they exercise, they're on statins, it often has very little impact on their disease burden. So those patients with a high LP little a, like we've had patients in their as young as teens, right? 20s, yep, that come to us because they've tested positive this test and they're wondering, what do I do about it when I have this information?
What do we do when we have a patient who ends up testing positive? Well, we lower their lipid profile to basically pediatric levels. We're used to hearing people say that, oh, my LDL cholesterol is 100. And so my doctor says it's fine. Well, for somebody who has positive LP little a, we want their LDL cholesterol to be below 60, right? So we're trying to get them down to pediatric levels. And that's where your cholesterol is from the time that you're 0 up until you're 15, 16 years of age, when you've started to develop adult habits, bad habits, and adult bad diets. So during the stage of life when kids are in their highest growth phase, they survive perfectly well on these low cholesterol levels. So an ApoB level less than 65, LDL cholesterol level less than 70. That's where we want those patients to be at if they're positive LPA. In addition to the other things that we always worry about in our patients, right? Which is making sure that they have no visceral fat, that their blood pressure is under control, right? That they have high lean muscle mass, that they have a high VO2 max. So one of these things that's super frustrating about this is that we've kind of known about LP little a since the 1960s. It didn't start getting notoriety up until the last decade, but now hopefully we're going to start treating it a little bit more. You want to talk about some of the treatment options?
Yeah, so some of the pharmacotherapy that we use, so niacin is a medication that will give us a 20 to 30% reduction. There's PCSK9 inhibitors, which are in the pipeline, and those can yield a 25 to 30% reduction, which is a nice bonus effect. And there's some new classes of medications in the pipeline, and those will yield an 80 to 90% reduction. These are in phase 3 trials, which are ongoing. So hopefully in the next few years, we'll be able to offer that to our patients.
Yeah, right now the mainstay is we lower your cholesterol with statins and Zetia as much as possible. If you can't tolerate those, then we put you on the PCSK9 inhibitors, which actually do lower not just your ApoB, but also your Lp(a), like you said, 25 to 30%. And that's the mainstay of treatment right now up until this new class of drugs hopefully hits the market.
And those PCSK9 inhibitors are super pricey, right? A couple $1,000 a month. So we often have to prove to the insurance company that this patient really requires this medication. So we're giving them their Lp(a) numbers, ApoB numbers, and we are jumping through hoops to get this medication approved.
Unfortunately, this is the paradigm in America, right? Like we have to prove that in order to get them approved, you have strong family history of early MI, like that. You have to, exactly as you said, you got to jump through hoops.
Yeah, you have a patient in his 30s, right, who has had a heart attack already. And that patient, we had to do multiple prior authorizations, which is basically the dumbest thing you can think of. Like we write a prescription for a medication and then it's the insurance company coming back to us and basically saying, are you sure you want to write this prescription? Like, yes.
Prove
Yeah.
to us that this person needs it.
Yes.
Like, wait, this guy already had a heart attack.
Right. It's so frustrating.
Yeah. So bottom line, high LPA means that we got to work extra hard to control all of the other modifiable risk factors, right? So blood pressure, ApoB, diabetes, smoking, exercise, weight. Basically, we got to overcompensate for the genetic bad hand that was dealt.
I know. So the conversation that I sometimes go over with my patients when they're like, man, I got dealt this hand of cards. And it's kind of like, I have these Irish patients that they can literally drink like a 12-pack of beer and never get liver disease. And then I have other patients that they drink like four beers a day and they're getting elevated liver enzymes, or sometimes even 4 beers a week. It just depends person to person. And so that's why this is such an individualized approach. You can't lump everyone in one category. All right, so let's go to evidence-based interventions and what actually works. Vikas, let's start with some lifestyle issues, both the most important and the hardest things to implement.
So diet, there is this kind of nutritional theology, right? So there are zealots for every type of diet out there, whether it's Mediterranean, keto, carnivore is so popular right now, plant-based. It turns out there's like not any one true like holy grail of diets. That being said, there are some that have much better evidence than others. So the one that probably has the most evidence is the Mediterranean diet. And there was a trial called the Preventable trial. And basically that showed that if you are following a Mediterranean diet rich in olive oil, there's a 30% reduction in major cardiovascular events. And basically, this wasn't a restrictive diet. This basically says that you're in general following a Mediterranean diet with vegetables, fruits, whole grains, legumes, nuts, fish, olive oil, and you're just eating less of processed foods, less red meat, less refined sugars. And they even allowed alcohol consumption, saying moderate wine consumption at 1 drink a day for women, 2 drinks for men. And that still netted a 30% reduction in cardiovascular events.
And the alcohol recommendations have evolved since then. So we'll talk about that during a different episode. But yeah, a major cardiovascular risk factor we know is ultra processed foods. So why does the Mediterranean diet work? It's because you're basically cherry picking whole foods. And if you listen to one of our previous episodes, we take a deep dive into what makes ultra processed foods and why they're so dangerous. So if you cannot recognize the ingredient list on these foods, it's not worth consuming.
Yeah. If your great grandmother wouldn't recognize it, we don't recommend it.
For sure.
So, what about exercise, Niche?
Yeah. So the good news is about exercise, you do not need to be an elite athlete. We require 150 minutes a week of moderate activity to yield you guys a 30% reduction in cardiovascular mortality. So that's basically 30 minutes, 5 days a week. And that's, if you want to break it down, that's 5 30-minute walks, 5 30-minute jogs, better than most medications without bad side effects. I would argue that exercise yields pretty much only good side effects, right? Better mood, better mobility.
Absolutely. There's no downside to exercise. As long as you're not hurting yourself, what is the downside, right? Exercise types that count, right? So, literally, it can be anything from gardening, dancing, playing with your kids, making sure that you're taking the stairs instead of taking the elevator, hopefully doing some resistance training at least twice a week. A combination of both aerobic training and resistance training is truly the holy grail. Like, that's what we need. We need both muscle activation from resistance training as well as general cardiorespiratory fitness from aerobic training.
Yeah. And we ask our patients to carve out that 30 minutes, 5 days a week, because as busy people, right, we tend to overestimate our activity. Like, oh, I walked to the train station or I walked to the grocery store. Well, that's good for your health that you're walking, but we really want that to be 5 designated 30-minute segments of exercise throughout the week to make sure you're hitting that.
Absolutely. So another thing that does make a difference that we should mention is statins. We kind of alluded to this earlier, and the evidence really is that really when patients are on statins, there's a 20 to 25% reduction in major cardiovascular events for every 40 milligram per deciliter decrease in their LDL cholesterol, right? And that is something that statins do very well. There are absolute benefits to being on a statin. Overall, high risk patients that are on statins reduce their risk by 20% for major cardiac events.
Yeah. And, we have some patients that come to us like, do I really need to be on that statin? And that's where we take that individualized approach. We're looking at their LP little a, their ApoB, their visceral fat levels, their lean muscle mass and VO2 max. And there are some cases where patients really are optimized in every other department. So I think we have a handful of patients who really don't want to take a prescription medication, and you have them on fish oil and optimized in every other department. So then we can say, yeah, if you don't want to take the statin, you will probably be low risk in the long run. But then there's those patients that don't want to take a statin. You're sitting duck if you've got high LP little a or high visceral fat, diabetes, and you're refusing the statin.
Statins have about a 5% side effect profile, right? So about 5% of patients either develop some muscle breakdown or liver function abnormalities. The liver function abnormalities are easy to test for. We screen all our patients with routine liver function tests. The muscle indices are, if patients start complaining of muscle aches, right, then we'll run a test to see, are they actually having muscle breakdown? When you combine all the muscle breakdown and liver function test abnormalities, it's 5% of people that have a problem, which means 95% of patients have no problem whatsoever with statins. They don't cause any major problems. We've heard everything from fertility problems to like conspiracy theory, like this is just a shill pharmaceutical trying to make money off of me and keep me unhealthy for the rest of my life.
It's literally a generic medicine. It's on the $4 Walmart list.
So beyond statins, what other drugs do we usually recommend?
Yeah, beyond statins, we talked about ezetimibe, and these drugs block the absorption of cholesterol, and it can reduce your LDL about 15 to 20%. And we covered the PCSK9 inhibitors, and that can yield a 50 to 60% reduction in your LDL.
Yeah, and the main problem with the PCSK9 inhibitors is their cost, right? So they can range anywhere from 6,000 to 14,000 a year, and that's a real issue, right? Access. We have to be able to access these medications. This is what we had mentioned earlier, that if there's not some documented reason for why the statin isn't working, getting approval for these PCSK9 inhibitors is difficult.
Blood pressure. So this is equally as important as all of the other categories. So the SPRINT trial is a trial that really changed our thinking by showing benefit from intensive blood pressure lowering. So if we can get our systolic blood pressure, which is that top number, below 120, rather than the traditional target of 140, that yields a significant benefit. And we have this conversation with patients. Well, yeah, doc, I know I have high blood pressure, but I don't want to take a medicine. Fine. If you don't want to take a medicine for your high blood pressure, that's fine. But we are starting you on a regimented exercise program. So you can't just sit there and have high blood pressure, because it's that cumulative effect over decades that is going to cause cardiovascular disease.
Yeah, blood pressure. The thing that blood pressure does is it hardens the arteries over time. The arteries are supposed to be flexible. They should be able to expand and contract. When they lose that flexibility, it causes damage to the walls of the arteries. And that's what causes the increased likelihood of plaque formation and then heart disease. So we used to think that once you were at below 140 over 90, that was the goal. What we've basically figured out through the SPRINT trial is the lower your blood pressure is, the better off you are. So now the recommendation is do whatever you can to get below 120 over 80, because that's the real goal. The lower your blood pressure is, the better off you are.
And that's why exercise is so beneficial. When you're stretching those blood vessels and making sure they're staying elastic for the long haul.
Exactly. You're right. That's what cardio exercise does, right? By making our heart contract harder to force more blood through the arteries, they have to expand and contract, expand and contract. The arteries themselves are exercising, and that keeps them compliant for the long run. That effect lowers our blood pressure overall.
So the key message is that blood pressure control is crucial, and we have multiple effective medication classes: ACE inhibitors, ARBs, calcium channel blockers, thiazide diuretics. And, that really is a conversation that you should have with your doctor about achieving your target blood pressure. Again, there's some lifestyle measures that you can take to reduce blood pressure without pharmacological therapy, but it involves an exercise regimen. And that's something that is non-negotiable if you do not want to take a medication.
Yeah, so let's kind of bring all this together with some practical takeaways. If someone is, listening right now and thinking, yeah, so what should I actually do? What are your top recommendations here?
Yeah, so if you're 40 and you're wondering, what should I be doing? What can I be doing? How do I take a proactive approach to my cardiovascular health? The first thing you should know are your numbers. Getting a comprehensive lipid panel, including traditional lipid markers like our LDL, HDL, and triglycerides, but also these newer metrics like your ApoB level and your Lp(a), which is that one-time genetic test that we talked about, getting your blood pressure checked, and some of your metabolic biomarkers checked, like your hemoglobin A1C, fasting insulin. You cannot manage what you don't measure. And so it's better to get a bird's eye view and get all these tests done. And for some of you that are over 40 with one risk factor, we do recommend getting that coronary artery calcium score.
Yeah, it's important to actually know what these numbers mean, right? So we get the test, we should know what the numbers mean, and you should feel empowered so that if your doctor just says your cholesterol is fine, you should be able to say, well, what does fine mean? Where is my ApoB? Is it in that healthy range where I'm pretty close to 65? Or is it somewhere around 90 where it is actually a risk factor?
Yep. And know your cardiorespiratory fitness, which is your VO2 max. VO2 max is the largest predictor of all-cause mortality. So it's important to not only get a baseline once, but be checking it annually.
You should also be considering advanced screening, as Nisha had mentioned. If you have any risk factors, that cardiac CT is super important because it basically can make it easier for us to figure out, should you be on lipid lowering strategy? Should we be more aggressive on blood pressure lowering? Because if you have a non-zero cardiac CT, then you already have evidence of heart disease.
And we have a bunch of 40-something patients that have borderline tests, and it's a huge wake-up call when they get a non-zero result for a coronary calcium score. There is evidence of cardiovascular disease. So we tell them, if you don't want to end up like your parents with a heart attack or a stroke or heart failure, like, you got to get it on this now before it becomes a problem.
I think also sometimes even primary care doctors will look at one of those test results and say, oh, your cardiac CT results showed that your score was only 10, right? So you're not in the high risk category. I think you and I look at this a little bit differently. Like, yeah, they're not in the high risk category because their score isn't over 100 or 200 or 400, but you already have heart disease, right? Like, you already have calcified plaques. So we should be pretty aggressive because we're concerned with what's your life look like 40 years from now, 50 years from now, not just what it looks like in the next 10 years.
Yeah. And in primary care docs' defense, a lot of this is dictated by insurance companies. And so a lot of these tests, even though we consider them preventative, they consider them to be done way too far in advance. We use something called the ASVD risk calculator, and that's literally only a 10-year risk calculator. Well, if you're calculating the cardiovascular disease risk for someone who's 40 to 50, yeah, that's probably going to be low. But if you're calculating a 20-year risk for that 40-year-old with high Lp(a) or high cholesterol or high blood pressure, that changes a lot.
I think that's a great point. We should also talk about reducing abdominal or visceral fat, right? So with our patients, we typically use a DEXA scan. As we've discussed in previous episodes, we think it's essential for patients to know how much visceral fat they have because that's one of your primary risk factors for impaired glucose tolerance and high blood pressure and high cholesterol. Once you know those numbers for yourself, then we can get you on a plan for how to start to reduce that number over time, thus reducing the number one cause for mortality, which is cardiovascular risk.
Yep. Visceral fat is a modifiable metric that we measure, right? So we encourage our patients to get a baseline and not be discouraged with that number because it's something that we all can work on. So we don't want you to completely overhaul your life overnight. That's a recipe for failure. I've been there. But we want you to pick one or two changes and make them stick before adding more.
Yeah, Mediterranean diet is a great template, right? So more fruits, more vegetables, more whole grains, more legumes, nuts, fish, olive oil. And we've talked about this previously, less processed foods. Overall, less processed foods. Red meats, it depends on the quality of the red meat, right? Like if you're eating steaks, that's not the same thing as going to McDonald's. So there's a difference in quality of red meats that you're eating, but refined sugars are a huge problem. And that is the main problem in American culture.
Yep. For exercise, like we mentioned, aim for 150 minutes per week of moderate activity. And if you can throw in a couple resistance training sessions, that would be great. But start where you're at. So even if it's a 10-minute walk and that's all you can do this week, aim for that. And then next week, shoot for a 15-minute walk. Something is better than nothing, and you've got to start somewhere.
This is also where the idea of the HIIT class makes a lot of sense, right? If you don't have 150 minutes of time, you can get away with less than that if you're doing high intensity interval workouts. And this is something that we utilize with our patients that are time constrained, right? If they're like, I've only got 60 minutes a week that I can do for cardio exercise and 16 minutes for resistance training, then I say, great. Those 16 minutes of cardio exercise, you're going to do HIIT training because you get the benefit of double that time by doing HIIT training versus just doing a fast walk.
As for smoking, don't smoke. You don't need a doctor to tell you that. And if you do smoke, quit. Ask your doctor. There's plenty of medications out there to help you quit. and also non-pharmacological therapy as well. There's no safe level of smoking when it comes to cardiovascular disease. Every single cigarette is harmful, and the benefits of quitting start immediately. That's why I think it's so interesting in medicine. We start telling patients in their teens and 20s, don't smoke. It's bad for your health. But we also need to start talking about cholesterol, sedentary lifestyle, as yes, all of those things are going to contribute to cardiovascular disease as well.
I think you're right. We've done a pretty good job of smoking. Like smoking rates have reduced significantly. Fortunately, obesity and inactivity has increased exponentially. And now we're seeing a lot of the downside of that.
Yeah, we've replaced smoking addiction with processed food addiction now. So, well, that's for another episode too. Another thing is manage your stress and prioritize your sleep. Chronic stress and poor sleep quality are independent cardiovascular risk factors. And this isn't just about feeling good, it's about keeping your heart healthy, right?
That's right. A couple things to think about here as we're wrapping up. You got to work with your healthcare provider and accept when appropriate medications are needed, right? If you're in that intermediate or high risk, you can't let perfect be the enemy of good. Statins and blood pressure medication are highly effective. They're generally super well tolerated, and there's no reason not to be on them if you need a little bit of help to get your numbers where they need to be.
And we have plenty of patients that we set goals with them. If they can get their blood pressure down, and they're incorporating exercise and HIIT workouts and really dialing in their nutrition, we can get them off their blood pressure medications and statins. So this isn't a forever thing, but you can't not do the lifestyle modifications and not take medications and just say, I want to be healthy. That's not how it works.
This is literally, right, playing the long game, and which is the name of our podcast. Every healthy choice that you make today is just an investment in your future.
Yeah, the data is clear. Cardiovascular disease is largely preventable. Estimates of 90% are preventable. And it's the number one cause of morbidity and mortality in our country right now. We have the knowledge and tools to dramatically reduce this risk. And the challenge is going to be implementing what we know consistently over time.
And remember, it's literally never too early or too late to start. Whether you're 25 or 75, the interventions we've discussed can provide meaningful long-term benefits. Your cardiovascular system is remarkably resilient to positive changes.
Yeah, obviously, if you're starting in your 30s or 40s, the runway's a lot longer and we have a little more lead time to change the trajectory. But we've had patients in their 60s and 70s where we are altering the trajectory in just 1 year.
I know we're causing positive effect even on patients in the last third of their life. I know that the interventions that we make are extending the quality and, as a byproduct, the length of their life.
Yep. Before we wrap up, we want to emphasize that while we've covered a lot of technical information today, the fundamentals are pretty simple. Eat well, move regularly, don't smoke, know your numbers, and work with a doctor you trust.
Absolutely. Don't let the complexity overwhelm you. Start with the basics and be consistent. And just remember, small improvements in multiple risk factors can lead to large reductions in overall risk over a lifetime.
So that's a wrap on our cardiovascular disease deep dive. Thank you for joining us on the MD Longevity Lab podcast, where we are playing the long game. If you enjoyed this episode, please subscribe, leave a review, and share it with someone who could benefit from this information.
And remember, we're not providing individual medical advice here. Always consult with your healthcare provider for personalized recommendations based on your specific situation.
Until next time, keep playing the long game and keep those hearts healthy. We're going to try and cram everything we learned in med school and residency about cardiovascular disease into this
45
episode.
minutes. Okay, you can.
Okay, then don't interrupt me.
Then you started a joke first.
I'm trying to talk. Stop interrupting me.
Yeah, I didn't interrupt you first. You looked at me before your script was done.
Why is me looking at you a signal?
It's for me to say something.
I'm not looking at you to say something. I'm looking at you for eye contact. If you want me to be funny, just let me be funny.
Were you being funny there?
Yeah, I was. I am pretty funny. God.
Is this even recording?
I don't know. I pressed record.
Thank you for playing the long game with MD Longevity Lab. You can visit us at www.mdlongevitylab.com to learn more about how we can support you on your journey. Stay connected with us on social media at MD Longevity Lab for tips, updates, and behind-the-scenes insights. If you enjoyed today's episode, we'd love it if you subscribed, left us a rating, or shared it with someone you know who's also playing the long game. Thanks for listening. We'll see you next time.